Hello, and thank you everyone for joining us. And hello again to Adil. Thank you so much for joining us in clinic or paused whilst in between clinics today. And today we're going to be doing, we're talking about psoriasis. And I know psoriasis isn't the most common complaint, but it is one of the most severe issues that people do suffer from. And I actually have psoriasis on and off myself, so I can really understand the causes, but I'm very lucky that I don't have it that badly. So Adil, first of all, if you'd like to just quickly introduce yourself to everyone, if they haven't met you before, that would be great.
Great. Well, thank you everyone for joining. Thank you for having me. I'm Adil Sheraz. I'm a consultant dermatologist. I work in London. And my interests include psoriasis. So I run a specialist psoriasis clinic at the trust that I work at. And I also run a lot of other clinics and general dermatology and skin cancers. But I do have an interest in psoriasis. And as you said, it's a relatively common condition. It affects about up to 3% of the UK population. And that works out to almost about 2 million people, which is a big number. And that's the ones we know of. So it may be more than that. And of course, some people may have very mild psoriasis that they don't even know they have psoriasis, or it may affect areas where they're not expecting it to, and they've misdiagnosed it as something else. So yes, you're right. It can be a devastating condition of people who have it. It can be life-changing. It can affect mental health. We can get on to all of these things in a bit, but it's a condition that we have really good treatments for now. So it's definitely worth having a chat about this and discussing the various options we have.
And, as I just said before we started, is that I think it is so important when you have a chronic condition, just because you saw the doctor 15 years ago who diagnosed you with psoriasis and you might carry on with the same creams, things change. And keep asking your doctor, and it is a question of keeping up to date yourself with stuff, because as we know, the GPs in particular have such a limited amount of training to start with on dermatology, let alone whether they manage to keep up with advancements in skincare.
Yeah, absolutely. I think particularly with psoriasis and other conditions like eczema, there have been huge progresses made in the last few years. And in fact, for psoriasis, I mean, there's a new drug being released almost every few months now. In the last few years, we've had so many new medications that have been put onto the market for psoriasis, and they've been life-changing. So yes, it's always worth having a chat with your GP or with your dermatologist to see what's available now. Things have drastically moved forward over the last 4 or 5 years, I would say.
I mean, and I remember when I first was diagnosed with it, and I heard some horror stories, how people, people can just have a little bit, or they can have it so severely, they're admitted, they're in and out of hospital all of the time. Is that still the case, that people can still have it that severely, or have drugs progress that much more to stop that?
We definitely have better drugs. We do have drugs that prevent those kind of admissions. However, we still very often will see patients in a situation where they are erythrodermic, which essentially means their whole body is covered with psoriasis, and we have to admit them and treat them as an urgent emergency patient. So we still see that, but we have drugs now whereby if we do see that, we can get a grips on their condition pretty quickly.
Oh, that's really good to hear. Okay, so if I just start going through some people, and hopefully people that are listening, I managed to cover some of your questions. Some of them are quite similar, so I have grouped them together. Yeah. The first one I'm going to ask you is actually somebody who didn't put their name in. So this is a nameless person. Is there a test to find out what type of psoriasis you have?
Okay. Well, first of all, I guess you need to... we can briefly just quickly hit on the different types of psoriasis. So psoriasis can affect your skin, it can affect your joints. Those are the two main areas that it affects. There are other things that it can have an impact on, but these are the two main things that it can affect. So first of all, you need to work out, do you have psoriasis in your joints or your skin, or do you have both? Now, if you have psoriasis on the skin, it can present in a variety of ways. It might present as typical, where you get the typical scaly, silvery, red plaques on your elbows, your knees, a bit in your scalp. That's called standard plaque psoriasis. You may get it in little dots across the body. That's called guttate psoriasis. And guttate is Latin for drop. So they look like little tear or raindrops on your body. So that's why it's called guttate psoriasis. You can have what's called inverse psoriasis, which is psoriasis that affects areas under your armpits or in your groin or under your breast. So not the typical areas, that's inverse psoriasis. You can then have pustular psoriasis, where you may have little, they look like whiteheads or pustules on your hands or your feet. You can have nail psoriasis, where it just affects your nails, and your nails look all yellowy and they look like they've been destroyed, essentially. So these are the different types of psoriasis. Now, the diagnosis of what type of psoriasis you have is almost always clinical. There isn't really a test to say that you have this type of psoriasis. It's mostly you examine the patient, take a history, look at the type of psoriasis, the distribution, what it looks like, and then you give it a name. And people often have combination of different types of psoriasis as well. So they may have a plaque and they may have guttate, or they may have plaque and psoriatic. So they will have combination of the different types of psoriasis. So there's no test really to determine what type of psoriasis you have. If we are not sure whether you have psoriasis or whether you have some other condition, we may biopsy your skin. So we'll take a part of your skin, send it off to the lab, and that's a biopsy. And we look under a microscope. But that necessarily won't tell us what exact subtype of psoriasis you have. It'll tell us you just have psoriasis. And then it's up to us as dermatologists to tell you what type or subtype you have.
And so do people get very confused between the eczema and psoriasis? Because they can look, so especially if you've got it on your elbows, they can look similar, can't they?
Yeah, so they can look similar in certain situations, but generally psoriasis affects the extensor surfaces, which means that it affects the outside of the elbow or the knees, or the kneecaps, whereas eczema on the whole affects the flexor surface, which means it's usually on the inside of the elbows or behind the knees or around the neck. So that's a very basic difference, but that's what you'll tend to see in patients. Now, there will be overlaps and there will be unusual cases where it does the opposite, but that's generally what it is. And they're two very different conditions, and the treatments are also quite different. They present very differently. Eczema tends to be very red, inflamed. It can affect all these typical extensor areas all over the body, keeps you awake at night, very, very itchy condition. Associated with asthma and hay fever, whereas psoriasis is different. Psoriasis, it's a different set of cells in the body that are irritated or inflamed that are causing this problem, and it causes a pileup of dead skin essentially on your body. Now, your normal skin should be turning over in 3 to 4 weeks. So a layer sheds, you get a new layer in 3 to 4 weeks. In psoriasis, that process happens in 3 to 4 days. So you were just turning over way too much skin in a very short period, which is why you build up that layer of thick, scaly, silvery scale on top, and then you have the red inflamed areas underneath. So that's the basic difference between the two conditions. And yes, people do sometimes get confused and they're not sure whether they're eczema or psoriasis, but you can see your dermatologist or your GP should be able to tell you what the difference is.
And I'm really interested in the fact that you can get two types.
Yeah, you could have a mixture of different types. You could have plaque psoriasis with psoriatic psoriasis, with nail psoriasis. Very common. We see that quite a lot. And again, psoriatic arthritis is something we regularly check for in our patients with psoriasis. And everyone should really be screened to see whether they have psoriatic arthritis.
Oh, well, we've got a couple of those questions coming up. Okay, Jennifer. This is quite a sort of all-encompassing one, so it may not be so easy to answer. Jennifer says, how do you get rid of a psoriasis rash? But I suppose it could be any form of psoriasis rash. Yeah,
the treatments remain relatively similar for the various types of psoriasis. There will be a few minor differences depending on the type of psoriasis, but on the whole, the treatment is pretty similar. And there's a ladder. There's a whole ladder of treatment that we will use. We will start off with topical treatments. We will then move on to potentially treating with light phototherapy, which is UVB radiation. And then we will move on to systemic medication, which are tablets, and some are immune suppressants, some are not immune suppressants. And finally, we have newer medications called biologic agents, which are injections, which are very, very good. But it all depends on how much psoriasis you have, where it is, how much it impacts you, and where you'll be placed along this ladder in terms of how we start. We like to start from the safest options and move upwards towards the more sort of hard-hitting treatments.
And so where roughly, because I think one of the questions that somebody posted, of steroids. So we will come on to steroids because somebody does ask us about steroids. So steroids, where would they fit in that chain of, you start off with just topic sort of
topicals?
creams?
Yeah, it starts off at the beginning. So steroids are right at the beginning, along with a combination of non-steroidal creams as well. So we know that steroids work well for psoriasis. However, we also know that steroids topically have side effects. So we have to balance the risks and benefits. Steroids in the long term will cause skin thinning. If you overuse steroids, you may actually end up causing your psoriasis to flare up when you eventually stop. So it is important to give the appropriate amount of steroids, and they work very well. People do have this bad sort of opinion about them generally, and they get a bad reputation, but there are excellent treatments, very safe if used correctly, and they work. So we always start off with moisturizer, steroids, plus a non-steroid cream. And we sort of mix and give people regimes of how often to use a steroid, and then when to stop, and then when to use the non-steroid. And then if that works, great. Or if it does work and they're finding they're using too much, then we will advise them to move on to the next stage of treatment.
So, I mean, there's a lot of products around that say, and I know from, the people that we work with, they've got to be very careful whether they can say that they can put psoriasis on the label.
Yeah.
So the ones that you can buy just over the counter, there's a lot of popular ones. Would you suggest you can use those at the same time as using your steroid cream, or you start off at home with them? Yeah,
I mean, if you're buying things over the counter, the likelihood is that you could probably use those with your steroids, or with the treatments that your doctor or your GP has given you. Anything prescribed, of course, you need to discuss and make sure that you're not using either double dosing with steroids or using things that might inactivate other products. But generally, over-the-counter products, yes, you can use along with the treatments we will give you. Always mention what you're using, and then we can advise you whether it's actually worthwhile even doing that, because your dermatologist or GP may be able to suggest better over-the-counter products for you to use.
Yeah, and it's so hard as somebody that doesn't know, how on earth do you choose whether one's a good cream or not? And that's relevant to anything, really, isn't it? Whether it be acne, eczema, etc. Okay, this slightly off is Diane. Why do GPs and some dermatologists have little to no knowledge that psoriasis can affect multiple organs, joints, and soft tissues? Well, first of all, do you agree with that?
Yes, psoriasis is more than just the skin. Definitely, I agree with that. I guess we've known about psoriatic arthritis for a very long time now. So psoriasis can affect the joints, and it can be quite severe. Your joints can become very deformed. And it can affect your function. You can become very crippled with psoriasis if it affects your joints and it is not picked up early or treated. So yes, that's something we tend to screen for our patients. More recently, there has been a move towards classifying psoriasis as more of a systemic condition rather than just a skin condition. And by systemic, I mean it affects more than just the skin and the joints, but other areas of the body. So we know, for example, that patients who have psoriasis seem to have a higher risk of cardiovascular problems. So they seem to have a higher risk of heart attacks. They seem to have a higher risk of diabetes, high blood pressure. And all these things are increased in patients if you have psoriasis. So now, as part of a lot of the dermatology clinics or specialist services in dermatology, we will check, for example, their cholesterol and their lipids and keep an eye on their blood pressure and make sure that there aren't other systems that are being impacted by the psoriasis. And the modality is not fully understood as to why this happens. We know there's an inflammation in the body, just like there is in the skin when you see psoriasis. There's also the similar inflammation in your body, and that may be causing these various systems to be upset and increase your cardiovascular risks.
But I mean, having said that, generally it's always very good to check your cholesterol, and those the cholesterol being the hidden thing that you don't know.
Correct, yeah. So, and you won't know you have raised cholesterol until you really check it. And a lot of times you won't know you have high blood pressure either until you get it checked. So yes, it's worth getting these things checked. And your diabetes levels as well, so your blood glucose levels, it's worth getting those looked at. And yeah, it's important to look at that. And one other factor that we haven't really hit upon just yet is the associated mental health problems that go along with psoriasis. And we know, for example, that about, I would say, 20% roughly of patients who suffer with moderate to severe psoriasis take an antidepressant, for example. 1 in 10 patients with psoriasis have thought about suicide, and about 5% roughly have active thoughts of suicide with psoriasis. It's a high percentage. It has a significant impact on mental health, on patients' mood, the way they see themselves, the way they perceive others see them. So it's a factor that, again, we take into account in our specialist clinics. We like to ask about these questions, how it makes them feel. And there are various scores that we will give patients and forms to fill out to see how it's impacting their mental health.
And I mean, that is the problem with chronic health conditions anyway, is because it's this long-going type of stuff. And so when you're saying about the mental health side, it's based on the fact of people's appearance, of coping with the disease, or is it also to do with the pain, or is it mainly appearance that people find is the main?
No, I don't think it's mainly appearance. That will be part of it, I think. However, it's the condition itself is very itchy. It can be sore. But if you have it, for example, on your hands, I mean, you can't function. You may not be able to go to work. You may not be able to do things that you wanted to do. If you're, for example, a swimmer, and that's part of your job, for example, you can't do that because you don't want to get undressed. So there's lots of factors where it's not just the appearance. It's actually the physical problems that psoriasis causes, the pain, the itching, the bleeding that it results in, that impacts people's lives. So yes, appearance is partly related to the associated mood issues, but it's also the actual symptoms and signs of the condition itself.
Yeah, and I don't think, I mean, I know that we did a thing once on eczema, and it never crossed my mind how it's fat people, which will be the same as psoriasis, people can't dress themselves, and obviously they can't go to work. And if you don't have those issues, you don't understand what the implications are.
Absolutely, so, yeah, absolutely.
Right. Joanne says, how can you treat psoriasis on the scalp? I've been doing it for years by dyeing my hair, but is there a better way? And also we've got Deb also said, how can I care for psoriasis on my scalp, please? What's best to use?
Sure. The scalp psoriasis can be a bit tricky to treat, and partly because one of the treatments we use for psoriasis is phototherapy, which is essentially UVB, which is what the sun produces. And we have specialized clinics that deal with patients, and they come into a phototherapy booth with us, and we treat them. Now, if you're out and about and it's summer, your body will get a bit of sun, and maybe your hands or your elbows or your chest where you have psoriasis will clear. However, it tends not to clear on the scalp because you've got hair, and the sun doesn't get to your scalp because it's covered. So a lot of people find the scalp is a little bit more resistant to getting better, even in the summer. Now, there are lots of treatments available. The problem with scalp treatments is that most of them are quite messy. And there are also topical applications that you rub into your scalp. There are steroid applications. There are also tar applications. There are coconut applications. And they do work if you use them regularly, but they're very messy. They're smelly. They're difficult to get out your hair when you literally have to wash your hair 3 or 4 times before you can get them out. And you can't go to work with them in. So it's a matter of compliance with patients when we give them these treatments, and it's not easy to do, and I don't blame patients when they're unable to do it. So the treatment for scalp essentially is topical, and there are various topical treatments out there that we use, and even combinations. So you can mix, for example, a steroid application with, for example, a coconut-based or a tar-based treatment. If you're able to put up with the smell, it will work. It's just a matter of keeping up with the treatment. And if that fails, then you can move on to the more systemic agents, the tablets or the immune suppressants that we use for psoriasis, and they will probably work, but then that's more of an undertaking and more of a commitment for patients to be on that.
And I don't know if we've got one of those questions, but when you put people on, they've gone down to the next level and they're taking their tablets, are those something that you take as a low-grade tablet all the way through, or is it something you just take up when you're in a flare-up?
So there are a couple of ways we do it. If we see a patient in a severe flare-up, we may give them a short course just to get it under control, and then they can stop and see what happens. But there are patients that we've got these medications, they've been going on for many, many years now, 10, 15 years. They've been on either low dose or medium dose or even high dose, depending on what they need. And they've been on it for many years. We sometimes advise patients to stop treatment to see how they will fare. And if they flare up, we go back to the treatment. We find occasionally we might start a treatment, their skin clears, we advise them to stop, and they may remain clear for 3 or 4 years. And they're in remission, and then it may just suddenly flare up, and then we need to restart treatment. And other people who we just can't get off, they just need to stay on a low dose for the rest of their life. As long as these treatments are monitored carefully, they generally are quite safe. It's just about being monitored in the right clinic, in the right way, by somebody who knows what they're doing. And if they're done that way, they are safe treatments.
Right. And actually that sort of then leads me on to think about that. Would you put people who are showing a sort of depression, would you put them on a low grade depression tablet at the same time, and then look at, when hopefully the psoriasis gets better, you then take them off the depression tablet? Does that help? Or
so generally, as dermatologists, we on the whole tend not to start antidepressants. There are some dermatologists that we specialize in the mental health side of things as well, and they may well do that. But generally, what we find is a lot of the times, if you get the psoriasis to improve, the mood and the mental health will improve as well. So I think we definitely will get counselling for them. And here at my trust, for example, we do have in-house clinical psychologists who we can send our patients to, and they will give them other techniques or methods in order to reduce their anxiety or their stress levels associated with their psoriasis. So we will score them for their anxiety levels, and then we will send them to our in-house clinical psychologist, and they will be able to then decide what the next step is. And if they need an antidepressant, then often the GP tends to do that. Or if we feel that we need psychiatric input, then we will send them to a psychiatrist, for example. But generally, as I said, we find if their psoriasis improves, on the whole, the mood also improves.
Yeah, that's definitely good to hear. James, I'm concerned about developing psoriatic arthritis. I've had psoriasis for a number of years, and now I think I've got osteoarthritis. Could this be psoriatic arthritis?
Okay, so now psoriatic arthritis is present in about, I would say, 20 to 30% of patients who have moderate to severe psoriasis. So it doesn't really affect as many patients who have mild psoriasis. That's number one. Now, number two, osteoarthritis and psoriatic arthritis are very different. They're completely different, in fact.
Okay.
Osteoarthritis is essentially just wear and tear. If you're using your hands, your knees, or your elbows, hips a lot, you will develop some form of wear and tear, and that is osteoarthritis. That is different to psoriatic arthritis. Psoriatic arthritis is an inflammatory condition. It's not just wear and tear. It's not. Most people, as they get older, will develop some degree of osteoarthritis where their joints are a little bit worn out. But you won't develop psoriatic arthritis unless you actually have that condition. So if you have psoriatic arthritis, there are a few questions you should ask yourself. So first of all, start off with, have you got any joint pain? Number one. If you do you wake up in the morning with stiff hands? So if you wake up in the morning with stiff hands, and typically patients will say, I wake up, my hands are really stiff, and it lasts for about half an hour, and then the hands get better. That is very typical for a patient with psoriatic arthritis. So the stiff hands in the morning, half an hour, and then they get better. And that is not typical for other conditions like osteoarthritis or rheumatoid. They are different. They might last the whole day, or they'll get worse the more you use them. With psoriatic arthritis, they get better within half an hour. So that's an important question. Also, do they get any swelling in their hands? So do their finger joints sort of look like, we describe them as dactylitis, which is swollen fingers, almost sausage-like, in fact. So if they look swollen, that may be a sign of psoriatic arthritis. Another important thing is, do they get pain in their Achilles tendon? So that can be quite specific. If you've got an Achilles pain, that could be related to psoriatic arthritis. And also back pain, for example. Do you get back pain? Do you wake up in the morning or at night with backache? And if you do, that may be psoriatic arthritis. So a few important questions: hands, back, Achilles, and the pain lasting for 30 minutes in the hands. So those are important questions to check. And if you have any of those, get your GP or dermatologist to have a look at it. And it's important to start treatment early for psoriatic arthritis, because it is a progressive condition. It will get worse with time, and you can be left quite debilitated.
Right. I know we've talked about it, but is there a blood test for psoriatic arthritis?
No.
I made that up, did I?
So psoriatic arthritis is on the whole a clinical diagnosis, which means that it's diagnosed by a clinician by history, examination, appearance. That's generally how we diagnose it. We may add in an X-ray occasionally or ultrasound scans occasionally, which will give us added information, which will then confirm our diagnosis essentially. So you can't really, there's not one particular thing that you can use to diagnose psoriatic arthritis. Other conditions like rheumatoid arthritis, for example, there are some blood tests that you can do to help you, but that is not the case for psoriatic arthritis.
Right. And then I suppose just very quickly then, rheumatoid arthritis, is that more akin to psoriatic arthritis than osteoarthritis?
Yes, so rheumatoid arthritis is an inflammatory condition, as is psoriatic arthritis. And rheumatoid arthritis generally is treated by the rheumatologist. Psoriatic arthritis is a mixture of rheumatologist and dermatologist. Right. So for example, where I work, I run a clinic with a rheumatologist. So we sit in the same room together. We will see patients who have psoriasis and psoriatic arthritis. And it just, we end up getting a better treatment plan because both of us are in the room together, seeing them together.
Yeah, gosh. And it, you know, that they're all sort of things that one hopes that you don't develop as well, really, aren't they? For sure. Funny enough, I just mentioned somebody called James, and somebody that we just had a message. I don't know if you said that flashed up, said from a James saying, "I'm sorry, I'm going to have to leave. I'm going back to clinic." So I don't know if that's one of your colleagues listening in on you. Right, Caroline. I've just had a flare-up of psoriasis. I had it a few years ago and it disappeared after using steroid treatment. I'm now in the middle of another course and now it's come back again. Will it keep coming back? I suppose what she's saying is she's had a flare.
Yes, so unfortunately, unfortunately psoriasis is a chronic condition and there's no cure to it at the moment. We do have excellent treatments and we have people in remission. So we can treat it, we can't cure it. And I guess the important thing is to work out what are your triggers, and everybody will have some sort of trigger for their psoriasis. And occasionally we may not find a trigger, but the common triggers, for example, psoriasis are stress, very common. And I find people in stressful jobs tend to have more flare-ups. So if you can reduce your stress, that will help. Number two, smoking, that tends to flare it up. Number three, alcohol tends to flare it up as well because it sort of releases inflammatory cells that might flare it up. So these are a few triggers that you may want to consider in your lifestyle management and see if you can reduce those. We also find if you're overweight, you may have a high risk of psoriasis and it might be more difficult to treat. So again, losing weight or exercising will probably help. So see if there's a trigger for you. Throat infections, commonly associated with the gut-ache type of psoriasis. So if you've got a sore throat, or you've got any type of infection, really, you might find your psoriasis flares up. So again, controlling or making sure that if you do get a throat infection, get it treated early or get it looked at, that might be able to prevent you having that flare up. But yes, psoriasis is a chronic condition. It may well go into remission at some point, but it will flare up and look out for your triggers.
What is interesting, isn't it? Over the years, I've noticed how, you know, we always, when you're talking about chronic conditions, you never like to hear the word cure. But because so much progression has been made now, and it was nice to hear you say there isn't a cure yet, which suggests that we are getting closer, possibly, to be able to say we are, you know, there are possibilities of curing things that we thought we never could cure.
Yeah, absolutely. I mean, there's so much work that has gone into psoriasis now. There's a lot of research that has been put into this because it is a relatively common condition throughout the world. And, you know, we know the genes that are involved with it. We know the various cells that are involved with it. And the treatments we have now are excellent. And they will give people up to 90 to 100% clearance. So even people who are entirely covered will find that we can probably clear them for their psoriasis with the right treatment. So we are getting very good at treating psoriasis now. And hopefully, in the future, with all the research, there may well be something we can do to cure patients or prevent it from occurring in the first place.
No, that's great to hear. Anne, what percentage of people with psoriasis also have psoriatic arthritis, please? And I think you actually mentioned a percentage.
Yes, between 20 and 30% of patients with moderate to severe psoriasis will have psoriatic arthritis.
So it is relatively common then. Yeah.
If you're moderate to severe psoriasis, there is a chance that up to 30% you may develop some sort of joint problem.
So where's the distinction between from having mild? What would you classify mild? I mean, I'm sure it goes on one of those. Is it? Well, I know for eczema it's like poem or whatever it is. Well, where do you go over?
So we use various scores to determine the degree of psoriasis one has. We also, there's various parameters you can use. So you can use a scoring system called a PASI system. You can also use systems whereby you look at how much of the body is covered. But a lot of these systems are good. They give us some sort of subjective, objective measure. But we also need a subjective measure. So we use patient forms whereby they tell us how their psoriasis affects them as well, because that's an important factor in terms of determining how bad this is. But for example, if I have somebody who works with his or her hands and their hands are covered with psoriasis, but the rest of the body is fine, now for them that's severe because they can't work. But if I scored them, it wouldn't come as severe because it's just not covering enough of their body. So I think what you describe or define as moderate or severe and mild is very dependent on the patient, the location, where it's affecting. I mean, if it affects your genital area and you haven't had a relationship because of that, then that is severe for you. So, but on the scoring system, it won't be severe. So it's a mixture of where it affects, how it impacts your life, and also the scores. So it's a combination of these factors. But when we talk about psoriatic arthritis, in terms of this, moderate severe will be how thick the plaques are and how widespread it essentially is. That's what we talk about when we talk about psoriatic arthritis.
And I was just going to say, it's really quite nice, isn't it, that you're not going just by one particular score, because, you know, so many times people say, well, I'm this, and that, you know, you've got that label, and you think, well, actually, it's far more of a rounded thing that you need to look at.
Absolutely.
Right. Mary, how much UV treatment is allowed? I've heard that you can only have a certain amount, as my doctor suggested that I go on a course at hospital. Yes.
So UV treatment is very commonly used for psoriasis. It's also used for eczema and a few other dermatological conditions. It's on the whole very safe. You have to come into a hospital setting or an outpatient clinic, whereby you stand in a phototherapy booth. You do it 2 or 3 times a week. Each session lasts a few minutes. It starts off in seconds, and as time goes by, the time increases. And you do this for approximately 30 sessions. So 10 weeks or so, you will do this for. And it works very well. Now, how much are you allowed? Generally, what we say, you're allowed it once a year on the whole, and up to 200 to 300 sessions over a course of your lifetime. So each course will roughly be 30 sessions, and you're allowed approximately 200 to 300 over your lifetime, and once a year. Now, this will be also dependent on other factors. For example,
but does that mean once a year? That means you can go up to 200 years old.
So basically, 200 sessions. So
200 sessions. Yeah.
Sessions. So each year you're allowed about 30 sessions. Yeah, about 30 sessions. So, but that will also depend on what type of skin you have. Do you start burning when we put you in the light machine? Have you had previous skin cancers? And all these things will vary for different patients, and then it may not be suitable for them year on, because we'll say, actually, you know, your skin's damaged, you've had a lot of sun over the years, we can't give you light, or the light's not working for you and it's not suitable for you. So there will be reasons why we may stop or continue with patients. But generally, as I said, you're allowed to have 200 sessions, 200 to 300 sessions over your lifetime.
Right. And obviously it's not like going for a sunbed, is it? You don't get a tan from this.
You can get a tan.
Oh, you can?
Because it's UVB. It's the same radiation you get from the sun. You definitely can, and you will often get a tan. But the difference essentially with our machines is, number one, it's done in a clinic with specialists around. Number two, we will often test you beforehand to work out what the right dose for you is. So we will start you at the right amount of energy. We won't just give you strong radiation right from the beginning. We will test you, see what amount of energy do you require. And thirdly, every time you come in, you're assessed by a specialist nurse or a doctor if they're present, and they will then increase the dose as you go along and as your body tolerates the light better. Whereas a photo a tanning booth, for example, you'll just go in, they'll switch it on a certain time, and you come out again. And that type, and there are lots of other issues with tanning booths, with skin cancers and risks of sun damage and melanomas, etc. So we don't advise our patients to go to tanning booths to clear their psoriasis. We advise you to either go to a dermatology clinic, and the NHS provides this very regularly, or if you want to go out in the sun and you do it sensibly, that's fine. 10 or 15 minutes of sun with sunblock is all you need for adequate vitamin D and adequate sort of sun exposure. Make sure you don't turn red or burn. If you're turning red or burning, that's too much for you.
And then also, I know on the market, they've got these blue lights, haven't they?
Yeah.
Do they help?
There's no robust evidence to suggest they really work. Not for psoriasis. There's some evidence that they might help in certain other conditions like acne, but again, it's not very strong evidence. So I wouldn't really advise people to buy over-the-counter lights to treat their psoriasis. There are some phototherapy devices you can buy which give you UVB radiation. In the UK, there's no real guidelines of how to do that at home at the moment. So in the States, for example, they've got a whole system whereby they will tell you what machine to buy, how to use it, how often to use it, how to increase the dose. In the UK, that isn't set up as yet. So there may well be a place for home phototherapy, but a lot of our patients, for example, are covered with psoriasis, and or they have patches in various areas on the leg, on the arm, on the scalp, on the face, and it's not practical for them to sit home with a lamp, 15 minutes here, and then you move down to 15 minutes. And what I find is the patients who have tried to do it, they'll do it for a week, and then after that they'll give up because it's just not practical.
But it's like all these home things, isn't it? It's fine to do treatments at home, but only perhaps if you've gone to see a dermatologist or your GP to confirm you have got what you think you've got.
Correct.
And then how to do it.
Absolutely. I mean, and you don't want to, for example, if you've got a plaque of psoriasis that you're treating and you've got a skin cancer sitting next to it, which you didn't realize, you want to be able to treat the correct thing. You don't want to be making one thing worse and one thing better. So it's important to get a diagnosis, get a skin check, and then only use treatments that have been approved by your doctor.
Yeah, absolutely. Right. Vanessa, any thoughts, comments? Oh, actually, we've done this one on long-term use of steroid creams for psoriasis. So I think you said, yes, they are good, but supervised.
Correct. Absolutely.
So, yeah, and I think that we say that we've actually done a webinar all around using steroids and very much understanding the issues that people can get from misuse or misguided use.
Correct.
Or right. Lisa Marie, can you tell if someone has psoriasis if they currently have no skin flare-up?
Unless they have joint involvement, unless they have joint involvement or nail involvement, then no. I mean, if you don't have anything on your skin, there's no test or blood test to say you've got psoriasis. And if you don't have psoriasis and you biopsy the skin, it will not show psoriasis. So unless it's a clinical diagnosis. So if you see the plaques, you say you have psoriasis.
Okay. Karen says, how do you treat stress psoriasis?
So stress is a big trigger factor for psoriasis. And I guess it depends on what your cause is, really, and whether you can do anything to avoid that. There are lots of sort of mindfulness apps and relaxing, calming apps that are available now that you can just download, and they do seem to help our patients. But it's a matter of finding what your trigger is, what is a trigger for your stress, and seeing if you can avoid it. And I know that's easier said than done. Lots of people's jobs are very stressful, which they have to do and they have to go to. But we do know that stress is a trigger, and finding methods that work for you, whether it's listening to music or just relaxing or whatever it may be for you, then you try to employ those methods to reduce those flare-ups.
And I think also one of the other issues with stress is that you don't necessarily know that you're under stress, but your body comes out, that this is your body showing you the stress, although you may not feel it inside as such.
Absolutely, yeah. So I mean, it may be you might feel that you're not stressed, but your body is stressed, and you may not pick up on it. So it's important just to maybe slow down, have a think about what's happening and how it's affecting you, and whether that's playing a role in your flare-ups.
Yeah, absolutely. Okay, we're just down to the last. We've got 3 here, which I think was going to fit in nicely. Susan, what is the difference between eczema and psoriasis? But I think once again, we've covered that one, and whether it's at the top or whether it's more inside.
Yeah, so it's just I mean, they're very different conditions, completely different systems in the blood that are involved in terms of causing the 2 conditions. Eczema tends to go along with hay fever and asthma, and those are called the atopic conditions. Also, eczema tends to start off very young, and whereas psoriasis we see a little bit later on in life, maybe in the teens it starts to pick up, and then it might drop, and you might get another sort of peak at 50 odd years of age. Eczema usually is childhood, and then it might get better, then it might come back again, but it's slightly different. Also, presentation is different. Eczema, again, as I said, eczema usually on the inside, psoriasis usually on the outsides. Not always, but generally that's the case. And they look different. With eczema, you won't get layers of skin building up that are silvery and scaly, whereas with psoriasis you will. Eczema, we find people often get infected. The skin gets infected with eczema. Psoriasis, the skin tends not to get infected. So there are lots of differences between the conditions. And most GPs will easily be able to tell the difference, and your dermatologist, of course, will be able to as well.
Yeah, absolutely. And in fact, we just then had a question in, which I might as well answer now, from Vanessa. Can beta blockers cause flare-ups?
Yes. So there are a few medications that can cause psoriasis to flare up. One of them is a beta blocker. So a beta blocker such as bisoprolol or atenolol, and beta blockers are essentially cardiac medications that are used either for blood pressure management or to slow the rate of the heart down. And we know they can cause flare-ups. So if you can change those safely, have a discussion with your GP to get those changed. Other drugs that can also cause flare-ups are ACE inhibitors, so drugs like ramipril, which are, again, blood pressure medications. They can cause flare-ups. And also lithium. So lithium is used for patients who may have bipolar disorder, for example. We know that can also cause flare-up. So it's important to look at your drug history if there's anything that is causing flare-up.
Okay. Claire, does psoriasis get worse as you get older? Now, I think you sort of alluded it comes and goes. So I suppose the question is, does it get worse than where you were when you might have had it when you were younger?
No, not necessarily at all. So everybody's path is slightly different. It does not necessarily get worse as you get older. Your psoriatic arthritis might get worse if it's not managed correctly, because psoriatic arthritis is a progressive condition. So once you get arthritis in your joints, it will probably get worse if it's not treated. Psoriasis on the skin, however, will probably just be relapsing, remitting. It will come and go. You may have a flare up, and that could occur at any point in your life. As you get old, it doesn't mean you'll get worse as you get older.
Well, that's good. I mean, well, that's a positive there, isn't it?
Yeah.
Compared to psoriasis, arthritis. Our last one here, Sally. My daughter has psoriasis and is pregnant. Is her baby likely to also get it? And is there anything that she could do in advance? And and she says, I don't like to discuss it with my daughter as she finds the condition so upsetting, especially when she was much younger, which goes with the mental health side of it.
Yeah, it is. I guess it can be stressful if you've got bad psoriasis and you are worried about whether your children will have it. Now, the risk of a child having psoriasis, if one parent has it, is roughly 15%. If both parents have it, it's roughly 40%.
Oh God,
so because we know there's a genetic element with regards to psoriasis, there are genes involved that we are aware of now, and there's a 15% risk if one parent has it that the child may have it. Unfortunately, there's not much you can do to prevent that. There's no measures you can take to prevent that. I guess if you have psoriasis now while you're pregnant, there are treatments we can give you that are safe for pregnancy. And there have been recent advances in being able to give you very good treatments that are safe in pregnancy. So if you have psoriasis now, it's best that you get it controlled. Whether that will impact on whether your child will have psoriasis, don't know, is the answer. But it will have an impact on how you are. So if you have psoriasis at the moment and you're pregnant, you probably ought to get that controlled, because it means that your skin will be in an inflammatory state, as will your body, which is probably not good for the baby in the long run.
And then I suppose if you have a child, is to have a look out for it, but not to be too obvious.
Yes. Yeah, I guess so. I mean, there's not much you can do, unfortunately. I mean, as I said, the risk is 15%, and if we flip that, then there's more than 85% chance that they won't have it. So I guess look at the positive side.
Yeah, absolutely. And it's like one of those things, if you keep going on about somebody, they've got something, you suddenly, when somebody says, oh, you look tired, and you didn't feel tired, you suddenly feel tired. You suddenly feel really awful.
Yeah, absolutely.
Yeah. So that's it. So hopefully we covered everybody's questions. I know that we possibly won't have, everybody would have been on the webinar, but I will guarantee they would go and listen to us. So yes, and then we've got to look forward to seeing you 2 more times this year. I think in April it is, what is it? Is it acne again? I can't remember.
Yeah, possibly one of the two. Acne, and there's one more.
And then we've got skin cancer in July.
Skin cancer, right? Okay.
I'm sure it's skin cancer in July, because I felt April may be a bit too soon for people to start thinking about skin. Well, it's never too early to start thinking about skin cancer.
No,
but
we see it all year round, so it's important. And now with cheap holidays and affordable holidays, people are getting more and more sun anyway during the winter. So it's an important topic any time of the year.
Well, are they cheap, or is it now just everyone's desperate to get abroad?
Or maybe, I don't know whether it's cheap or not, but maybe it's just more, I mean, people go on more holidays now than they did many years ago, I think. So we do find that the risks, that the numbers of skin cancer are definitely going up year by year. So it's an important topic at any point. Yeah.
Okay. Well, that's brilliant. And as you know, I actually have guttate psoriasis, and so for me, it's been really interesting. And my psoriasis started because I had a sore throat. That's how it started.
Yeah, so strep A usually is the cause. And guttate psoriasis responds very well to phototherapy. It's the best treatment for it.
And I've had it. And I can just remember going in there and putting a blooming pillowcase over my head. And I didn't go brown, which is why I was thinking,
You might not have had... so we try to keep the doses that are appropriate for you. We try not to get you too dark, because it will cause some degree of skin damage. So, and then we have visors rather than a pillowcase.
I mean, I know that it is. I was very lucky that I didn't suffer from depression, but I had it twice. I've had it where I've been covered head to toe, and they've been really. And I was like, oh my God, am I ever going to be able to walk outside again?
Yes, I know
it is horrendous, and I just feel I am so lucky that I just get a few little spots here and there, and so I really feel for people that have very bad psoriasis. They have all my sympathy. It's not great.
Yeah, absolutely. It's a difficult condition, tough condition, but very treatable now. So just see the right people.
So when I got mine 30 years ago, that really wasn't great. And we had the singing detective on television, and that's all. Well, you're probably too young for that, but he was in bed all the time. It was horrendous. Anyway, really lovely to talk to you again, and we'll see you again in April.
Thank you very much, Katrina. Have a lovely yesterday, and thank you everyone for joining.
Thank you.
Bye.
Bye.